to you.
Thank you. So I'm Karen Hayllar. I'm the statistician in the Making Data Count team, and I can only say thank you for the advert. I am very passionate in my role at helping organisations use data better to make better decisions, and that's what I'm going to show you. We have, as a team, done over 200 sessions with trust boards, with ICB boards, looking at how they can use their data better. And through our post-COVID training sessions, we've now trained over 30,000 people in these techniques. So if you want to know more, there are lots of opportunities to do that. But right now, because time is short, I'm going to share my screen and we're going to hope this works. So can you tell me if that's the right one? I think it is. Yeah. Okay.
Yeah, you're right.
Oh, I'm going to talk very fast. I always talk very fast. It's what I'm famous for. So why do I do what I do? I started 7 years ago. And when we started, we saw NHS reporting that looked like this. Some rag tables, some spark lines, some truly appalling presentations of data that really don't help anybody understand what's really happening. There was one I saw recently at a brilliant trust, but their reporting left a little bit of something to be desired. So what's this chart telling me? Is anything changing? How would I know? Do I have any idea about where I should focus? And what assurance do I have? Even where there's green, is that good enough? Are we going to hit the targets reliably? I personally think a summary page, like the stuff Joe's just shown us, should jump out and show you where you need to look and tell you what you're going to do next. We don't want to see stuff like this where we've got that 1 month trend arrow, or we might have a little bit of commentary. Now, I was a statistician back in 30 years ago, and I used to write this stuff. There's an increase from 95.36 to 95.76. Not necessarily important narrative, just distracting, and a bit like this. Now, I'm hoping some of you are old enough to know who Bruce Forsyth was. When I presented to the GERF registrars, not a single one of them knew who this was. So Bruce Forsyth used to play a game called Play Your Cards Right, and he used to play a game where we went higher or lower. And that's all he did. When we make those reports with that 2-point comparison, with those little spark lines or those arrows, that's all we're doing. Now, Alan Carr took the game over, so perhaps if you're younger, you'll recognise him. So I'm going to show you some data. It's not really a task for you, but this is a task I do with boards and with executive leader teams. And I'm going to show you some different forms of data. So here's my first one. It's a table of data. We're all familiar with this. If it's your data, you're probably happy with it. You know where to look. If it's not your data, it's really hard work. It's not analysis. It's just a data dump. And NEDs in particular, non-executive directors, will really struggle to know where they should be looking and what they should be focusing on. So not helpful. Another one. So I look at a lot of board reports. This is from a board report, and you can see that whatever these metrics are, and they're mental health metrics in this example, they're all green. So we're not going to spend much time on this page, but of course, hidden in there is a problem, because if we put that data onto SPC charts, they're going to tell you what those are in case you're not familiar, then we begin to see what the issue is. So one of those metrics in that sea of green was the 6-week referral data. And of course, when we look at the data over time and longer time series, we can see that there's actually a statistically significant deterioration in our process. Why is it green? It's green because it's marginally above 75%. And so it's green, but actually there's an ongoing problem. Now, why does that matter? It matters because when this trust dropped below 75% in the next month, there was a lot of fuss and bother, a phone call from the institution where I work, lots of requests for plans and reactions, and what are you going to do about it, and why has this happened? But the trust could have known several months earlier they had a problem. They might have been able to address the problem, stop it happening, or at least they would have had a plan in mind to tell NHS England when they're making that lot of fuss and bother, this is what we're doing, this is how we know what's going on, this is what we expect to happen. So that green in that sea of green really didn't provide us with assurance. It provided us with false assurance. And we need to be very careful about that. Now, I work with trusts and ICBs, and I'm a very, very pragmatic statistician. I'm all about really understanding your data and making good management decisions. Now, imagine this. We've got this red and green, and absolutely colour blindness is an issue with the board I was working with yesterday. As with nearly every board I've ever worked with, there was someone who's colourblind. They can't distinguish numbers on these. You can imagine we have got a table of red and green. In there is general surgery. Well, general surgery looks terrible, doesn't it? Red across the board with a down arrow, therefore not achieving the target for more than a year, and worse this month than last month. Now, you have to remember we're pre-pandemic here. We're looking for 92% as our target. And so the board have summoned the manager of general surgery in to give an account of their services. And the manager says, well, actually, I'd like to show you a different picture of my data. For the last year, my team have been working incredibly hard to improve our performance. Now, we absolutely acknowledge we haven't hit that 92% standard, but we have improved month on month for a really long time. We think with a little bit more effort, we can get ourselves over the line, and that'll be really good news. So I'd like you, instead of telling me off because it's red across the board with a down arrow, to congratulate my excellent team on the brilliant work they've been doing. Now, that's a totally different conversation based on better use of data over time. Well, let's have a look at another specialty. We'll look at rheumatology. Rheumatology, again, red across the board with a down arrow. Well, it looks like bad news. And in this case, we are actually in that position. So you can see that if we look at that data over time, and I should say all of this data is real data from trusts I've worked with in the past, you can see there is a statistically significant deterioration. I should have said at the beginning, blue represents good or improving performance, orange represents poor or concerning performance. So we can see that real deterioration in this data. And so we have a different conversation. Have you lost a key member of staff? Have the referral patterns into your service changed? How are you managing this? Can you learn anything from general surgery who are doing so well at the same time? So again, using the data better allows us to have a much better practical management conversation on the ground in our organizations, which is what we're all about. And of course, variation matters. Now, I'm sure all of you know this, but we know that there's all sorts of variation in the world, and it's really important we understand the different sorts of variation. So we get that normal everyday variation when we travel to work every day. Our journey doesn't take exactly the same amount of time. It varies, and that's normal. We'd expect that. We call that common cause variation, and yet NHS data is exactly the same. It has common cause variation, and we need to acknowledge that. Then we have unusual, special cause variation. Now, I would categorize that into two sorts. If you drive to work and you have a crash, that is definitely unusual. Well, hopefully it's unusual, unless you're a terrible driver. And so you would get that really long journey to work. It's completely different from every other day. You can see there on the chart, we've got that exceptionally high point because you have to stop, exchange insurance details and all of that stuff. So we know what that cause of that is. It's unusual, it's special cause variation, but it's a one-off event. What about this? When we get a new road layout on the way to work, perhaps our journey time is going to get longer. It might get shorter, but it'll be different every day in a sustained way. At the beginning, this is unusual variation. We call that special cause variation, but it becomes the new normal. And so we really need to understand and dig into that. And that's perhaps what we're going to focus on today. So that's why we need to understand. Now, the CQC absolutely agree that you need to understand the different sorts of variation. Back in 2018, they published this report which said that boards, and I would say at every level of every organisation, we should be looking at time series analysis and make a decision based on that understanding of variation. We should use run charts, control charts, not bar charts, not pie charts, and certainly not rag rating. So a clear steer from the CQC. And then more recently, the Bill Kirkup report said exactly the same, that we need to understand the effects of random variation, that we need to present our data graphically and understand significant trends and outliers. Now, I know that when Bill Kirkup wrote this report, he wanted it to be applied far wider than just in maternity at East Kent. These are general principles for good understanding of data in the whole of the NHS. Oh, come on, slides. Why does that always happen? Sorry, need to close that and go back to my slides. There we go. I need to take the live link off that slide. Okay, so in the NHS, we know that we get that common cause variation. It's kind of normal, it's part of everything. When we react to it, we do this, we spuddle, we make a lot of fuss about trivial things as if they were important. When we react to that normal everyday common cause variation, then we spuddle. In the NHS as a whole, we are always trying to achieve two things: to improve our performance, but also reduce the variability of the very services we deliver. When we spuddle, when we tamper in our systems, then we will do the opposite. We will increase the variability of the services. So it really matters that we understand when we've got got normal, everyday, common cause variation, and where we've got that unusual special cause variation. But how do we know what we're looking at? Well, we're going to use an SPC chart. You'd have guessed that. So making data count is all about statistical process control charts. This is an X chart. It's one of the whole family of SPC charts. But an X chart is like the Swiss Army knife of SPC charts. It will do most things pretty much. If you can count it or calculate a percentage, you can use an X chart for nearly everything. It has no assumptions about the underlying distribution of the data. So it's really, really useful. So what we've got that dotty line through the middle. That's our data. We've got the mean through the middle of that, just a standard mean. And then we've got those process limits. Now, the process limits are completely defined by the data itself. And that measure of variation we use is like standard deviation, but it's different because standard deviation doesn't care what order the data points are in, whereas when we use sigma for calculating the process limits in an X chart, that takes into account the order of the data. And so we've got 3 measures of sigma above the mean, 3 measures below. That's where the phrase 6 sigma comes from. And when nothing in our system is changing, 99% of our data falls between those limits. Now, I'm telling you all the stuff I teach to boards and to other people about using data wisely. So 99% of the data falls between those limits. We need a bit more data. So trusts have traditionally reported perhaps 12, maybe 13 months. Some trusts just do 6. You need a bit more data to make those points robust enough to make the process limits robust enough to detect your special cause variation. And then we need some rules, because as human beings, we're really, really good at detecting patterns in data. So here are the rules we're going to use. A single point outside those process limits, that's highly statistically significant. 2 out of 3 points near or outside our upper or lower process limit, again, statistically significant. Shifts of points above or below the mean, runs of ascending or consecutive ascending or descending points. All of those are signs that something in our world is changing and we need to pay attention. So it's quite helpful to have those signs, because what statistical process control will do for you is say, something's changed, I need to pay attention. It won't tell you what to do about it, but it will point you in the right direction. And just like Joe was saying, it gives you that ability to focus in the right areas. So I've already said, in my world, this is the making data count world. We highlight special cause. We do that on all our charts. In the Power BI suite, we've also got it in ClickSense. We've got it in Tableau. The R and Python communities have been very generous and developed these tools for us. So it's available to you, and whatever tool you use, if it's part of our suite, it will highlight that unusual special cause variation on your charts automatically. So orange for concern, blue for improvement, and purple if you just don't want to make a judgment about whether something's good or bad. So imagine cesarean section rates change. It's not good or bad, but you do need to know there's a change because you might need to investigate. So in those cases, we use the color purple. But we were challenged really strongly. We can't have that many charts. It's not helpful. So how do we get around that? Well, we came up with some icons which summarize 2 things: the variation in our data, so whether it's getting statistically significantly worse or better, and the assurance. Can the system we're looking at, can the process we're considering hit, miss, or flip-flop around that target? So you saw those icons in the stuff Joe just showed you, and I'm going to explain them slightly more, which might help some of you who aren't familiar with them. So imagine we have something that's getting worse. We want to be low, it's getting worse. So we've got that orange icon, which indicates we've got the orange dots to say this is going up. We get an orange icon to say that it's concerning, and the H indicates that it's getting higher. If we had some improvement, and imagine that in this case improvement is down, we get that blue L to indicate that we've got improvement because it's blue, L because it's getting lower. Now the other case, of course, is special cause common cause variation, where nothing is changing. But of course, grey is not always good. So if you are not meeting a target and you're not improving, that's not a great place to be. So you have to remember, just because it's grey, it's not always good. Now, what about assurance? When we see a RAG table with those red and green squares, if we can see them because we're not colourblind, then perhaps we would think that it's telling us about what happened this month, last month, the next month. But we could do something much more powerful than that with SPC. We can understand whether the process is actually capable of hitting the target. So imagine this example. You can see here my dotted line, that's my data. You can see those process limits around the line. So nothing in this system is changing. The target I want to hit is above my upper process limit, so it's outside that range. So we know that this process, without intervention, can cannot hit that target. So it's a failing process. We get that orange for concern, F for fail. So we can't hit the process. Now, until the A&E standard was changed to 76%, this is where for most trusts in the country, their A&E performance was nowhere near 95%, well below the target, was massively above their ongoing performance. If we have a system like this is a capable process. So you can see here my dots are in between my process limits. The target is below the lower process limit. Obviously, this works both ways up. If the target is low, then it would be the other way around. But in this example, we want to be above 10. You can see my whole process and my process limits are above 10. That means I'm going to easily achieve the target. It's a capable process. At that point, you might be asking your questions about, should we change the target, make it more ambitious? Or should we remove resources to some other service which is not doing quite so well? With both of those, I would celebrate your success before you make your world more difficult. And then we come to the last position. So this happens when the target line's in between those process limits. So you get your data flip-flopping and failing and passing that target, and you will get that on a rag table. So if you see a rag table that's flip-flopping between red and green and red and green and red and green, that'll be because the target line is between the process limits. The closer the target line is to the mean, the more likely you are to just flip-flop, and so it's an unreliable process. If all you want to do is achieve the target over time for the whole period, then it might be good enough. If you want to provide a good service to your patients in any month, then you need to improve that service. You need to intervene. Now, I'm sure most of you have come across SBC, and you'll have probably come across it in the context of the model for improvement. But nowadays, across the whole of the NHS, in all sorts of trusts, we're using these techniques to monitor ongoing performance, to understand when our performance is getting better, when it's getting worse, and really, really importantly, whether we can hit or miss those targets, because we need to know whether the interventions we're making are going to make the difference that we need. So I thought I'd show you a couple of examples. This one looks at something which is very sad, because this is a trust who were working really, really hard, but they did at least take some rigorous steps. So they wanted to improve the number of falls in their organisation. They made lots of interventions. You can see those are all annotated on this chart, lots of stuff going on. But when they looked at the data, you can see that all of that effort really made no difference. Now, that's very sad. I'm sure for this trust it was a right pain. So they didn't manage to improve the number of falls in their organisation. But we do have to always acknowledge when that's true, because perhaps there are some questions we need to ask. Were they the correct interventions? Did we implement them properly? Are there any factors we should have considered that we didn't consider? So it's very informative if we're doing improvement work, and absolutely vital that we make a baseline and then monitor our ongoing performance and see if what we've done actually worked. Now, let's consider something more slightly different. So this is the A&E performance for a trust. I can't remember which one. It's one I was working with recently. And you can see that even with the 76% standard, we've got a problem. We've got deteriorating performance over quite a long period of time. Now, we might want to say, is that because attendances have gone up? It's the obvious answer. Whenever I go to an organisation, I say, your A&E performance isn't good. And they go, oh, it's attendances. We've just got more patients in our trust. And I go, well, show me your data. And you can see in this example, that wasn't the case. Now, those of you who know anything about SBC know that this should be recalculated on the upper chart, but we're not going there because I haven't got time today. If you want to know about that, come back to me another day. So we've got our 4-hour performance, we've got our attendances, but then I might want to ask another question. What's actually going on in the rest of the trust? Because we know that all of this stuff is about flow through organisations. So is your occupancy high? Well, it is quite high. It's not outrageous. I've seen worse, but yes, the hospital is quite busy. But perhaps this might be something you might want to pay attention to. So we've got a lot of beds blocked by patients who no longer have the criteria to reside in hospital. They need to be discharged. So is that the question? So you begin to be able to tell a much richer story if you put these charts alongside each other and consider those metrics together. So that's one way of doing it. But of course, it's not just about the pictures. In my world, it's all about what you write about pictures. And here's an example you need to avoid. So we looked at this trust, and you can see that they said, oh, there were pressures in the system. We needed to know about that, didn't we? And then there was a recovery in March. And then, well, we had some more pressures further back and a good recovery in June, and sustainment was difficult in July, and August shows improvement. So all of that going on. Now, because I can and because I'm a very naughty statistician, I put all the data onto a chart, coloured the dots red or blue, red or green, depending on if they hit or miss the target. Now, you will see that actually, and then I can put in where those comments were made. Now, the sad thing is someone went to a lot of effort to write that commentary, and actually they might as well have said, it went up, it went down, it went up, it went down, because that is all common cause variation. Nothing to write home about here. We have got very, very wide variation, so there are some questions I would be asking, and you can see that that mean is incredibly close to the target line, so we're going to hit and miss the target randomly. There are some things I would be saying. I would be saying something like, let's be really honest about the data we're seeing. The measure is not changing significantly. The target will only be achieved randomly. Process redesign is required to achieve the current target consistently. And that is just the beginning, because from that comes the, so what am I going to do about it? And that can only come from our clinical and operational colleagues. So it's always a handshake between the two teams. Good narrative will tell the story of the data, consider that variation. You should see it highlighted on your charts in your summary tables. Identify significant changes where they are, highlight where action is required. At that point, we have to stop and take a breath, because there are a lot of things in the NHS which are in crisis at the moment. And so we might need to ask the question, is this an organisational priority? If it is, we're going to identify the actions, who's going to do it, when are they going to do it, how are they going to do it, when will we expect to see the improvements we're making have a result. Together, if that appears in our narrative, we will have excellent narrative, which adds value and is action focused and acts as a brilliant audit trail going forward. Why am I talking to you about this? Well, because I don't want to see anyone running around like a headless chicken. When we use data better to make better decisions across the broad scope of the NHS, it's our patients who will benefit, because we're making the right choices based on the real data we have. We have loads of resources. We have our interactive PDFs. We do training every month. If you're interested in more, please come on the training. It's all CBD accredited. And I think, oh, and we have a future site. You can access the whole lot through the future site. And I think that was my blast through my stuff.